Good morning, everyone. So we're going to begin the IC, and the IC is called Let's Level Up. This is an IC comprising of all the recent updates in the different specialities of ophthalmology. To begin with, we have Dr. Neena R. She's the head of pediatric opthal in Giridhar Eye Institute. Over to you, ma'am.
Thank you, Sugranjini, and Sugranjini is always up to date, and it's a pleasure to be with her in this interesting IC. So I'll be talking about what's new in pediatric ophthalmology. So the paradigm one would be the change in the way we care about children. Now, pediatric ophthalmology is no longer something that general ophthalmologists do as a part of their majorly adult clinical practice. It is definitely a super specialty or a specific subspecialty now, and we have child-focused dedicated pediatric ophthalmology clinics with pediatric ophthalmologists, optometrists, orthoptists, and nurses. So the target or the thrust is to provide facilities which are specifically pitched towards children with experienced staff and appropriate safeguarding and training. The second paradigm would be how we look at myopia management. The focus now is not just on giving glasses and treating myopia. The focus is on controlling progressive myopia. So with our new understanding of the genetic risk factors and understanding how the visual environment influences myopia, with pharmacological options like low-dose atropine and optical options, we have a lot of things to do in the management of progressive myopia. So the visual environment modifications would be to reduce the screen times and sustained near work and to increase the outdoor time in sun. This is the norm that we follow now. And pharmacological options, low-dose atropine is already here, and probably what's going to happen is we're going to come up with the optimum concentration which is going to help us in attaining the myopia control. So Indian experience is also ample, and we've also tried this. The 0.05 concentration is soon going to be available in India, and that would be a new tool in our armamentarium. So the optical options, they are also available right now, especially the peripheral defocus spectacle lenses. So our understanding is that, you have a traditional correction which only corrects the center, and in fact, it produces a hyperopic defocus in the periphery, which acts like a stimulus for further axial length elongation, and that is the reason why the myopes continue to be progressing despite on an optimal glasses. So the aim is now to produce myopic defocus in the periphery so that the axial length elongation is prevented. So with this thought in mind, various prototypes are there. The first one was the DIMS lenses, or diffuse incorporated multiple segment lenses, which is currently the Hoya Mio Smart one is available in India. Then you have the Essilor's HALT technology, which is based on highly aspherical lenslet targets, which produces a volume of myopic defocus in the periphery. And then you have the latest, the Zeiss MyoK lenses, the CARE lenses, central annular refractive elements, which again focuses to provide a myopic defocus in the periphery. The new kid on the block would be the DOT lenses, diffusion optics technology. Now this thing's slightly different. So what they found was that when you have abnormally high retinal contrast signals, this was a stimulus for progressive myopia. So if you can reduce this contrast, it can slow down axial length. So they have incorporated thousands of microdots in the lenses, which is kind of doing the same function. It's not available in India yet. Contact lenses for myopia control are very much available abroad, but not in India, starting from the bifocal to the multifocal. So various prototypes are here, from Cooper Vision to Johnson & Johnson. These are not yet available in India. They also have the EDOF lenses, that is the extended depth of focused contact lenses, which again works on manipulating the higher order aberrations and reducing the contrast in the retina and slowing down the axial length elongation, not yet available in India. So there is a lot of exciting new vistas in myopia control on the way. Some new things which are being investigated now are low-level red light therapy, which says if you have a low-level exposure to red light of 650 nanometer, it was able to control myopia, but not been validated yet. Then you have virtual reality-based visual training, with which virtual reality headsets you're able to provide a visual environment which simulates outdoor activity. So that's going to be something new. Then Atom 3 is on the way in Singapore National Eye Center, which aims to prevent myopia even before it starts. Can you give it to pre-myopes and prevent myopia? That's what Atom 3 is looking at. And of course, studying the genetic polymorphism and using it in a positive way to control the myopia progression would be the last thing that we would like to look into. Paradigm 3 would be advances in the imaging and diagnosis like handheld OCT. You can see what are the applications right from cornea to retina to neurophthal to intraocular tumors management. Handheld OCT is a very big, invention which has changed the way. Of course, advances in IOP recording like the use of eye care tonometer, especially the eye care rebound tonometer, which you can use both in the prone and supine position, has reduced the number of EUAs we do for children, the children who need a regular intraocular pressure measurements, because it requires minimal cooperation, no drops, and it's quite fast. And you get a reliable reading, so you can avoid the EUAs. Paradigm 4 would be the development in preschool vision screening. It's a big challenge to screen these children without cycloplegic retinoscopy. How do you know what's accurate? So autorefractive screening, photo screening, and VP-based screening is here. And we also have used this. So this is a Welch-Allen spot vision screener, which we use widely for screening children. It is calibrated as per the APOS guidelines and picks up amblyogenic risk factors, and it's quite sensitive. So paradigm 5 would be the new developments in amblyopia treatment. So thrust is now not for monocular occlusion but for binocular therapy and improving the binocular vision. So we have various modalities like liquid crystal glasses, which uses an intermittent flickering shutter, so it can switch on and switch off between the amblyopic eye and give us some sort of binocularity as well as a monocular occlusion. Then you have revital vision, which is based on perceptual learning, based on the Gabor-Poch concept, and binocular therapy with like Binox and IBIT and dichoptic therapy. So these are some new things. Due to shortage of time, I won't be going into details. Paradigm 6 would be minimally invasive strabismus surgery using keyhole openings to do strabismus surgery instead of large openings. Difficult but achievable. Paradigm 7 would be readily available genetic testing. This has really changed the way we look at complex ophthalmic disorders or complex eye diseases which are inherited in children. And so with the new diagnostic modalities for deep phenotyping, combined with the genomic testing, we are able to come to diagnosis of complex inherited conditions, especially retinal diseases. And we are also doing it now, and we have promising discoveries like the Luxturna for RP65LCA, the CRISPR gene editing version for CEP299LC is already there, and the antisense oligonucleotide-based therapy is also there. Thank you very much.
Thank you for that excellent talk, ma'am. If I could ask you, among all this array of recent advances, what is exactly available for us at our disposal in Kerala specifically, or in our institute? Like, what do you feel?
Yeah, so all these we are doing most of the things. That's why I mentioned, like we have specific pediatric ophthalmology clinics now. Myopia control is, everybody is aware that we need to control, so we have optical aids like the peripheral defocus lenses are available. The DIMS, the HALT, the MyoK lenses are there, but the contact lenses are not available in India. The EDOF lenses also not available. The DOT lenses are also not available. Low-dose atropine has been there for a very long time. Then amblyopia management, the binocular therapy, we have Revital Vision in our hospital. A lot of other places have Binox. And the other ones are probably available on a smaller scale, but some of them are still in experimental stage. Genetic testing has become very, very affordable now, and we are using it. And the minimally invasive surgeries are yet to pick up because it's technically more challenging, but probably doable in the long way.
Thank you so much, ma'am. We can take a quick question from the audience if there are any. Dr. Raki, can I ask you to please take the stage in the meantime? After our pediatric update, we will be moving on to our cataract update by Dr. Raki D. Cruz. She needs no introduction. Over to you, Dr. Raki.
So a very good morning everyone. So I'll be talking upon the cataract hot picks. I'll be covering only the last 5 years what's latest and what's new in cataract. So as we all know, what is new in technology? In technology, we have the new machine, which is a size Quattro 700, which has got a patented Quattro pump. It has got an enhanced chamber stability independent of the IOP and flow. Also, this one has an automated ultrasound power on demand mechanism, which uses power only when needed, that is upon occlusion. And Dr. Sri Ganesh from Bangalore had a great role in the development of this machine. Now coming to the new in technique. So nowadays everybody has increasingly used the pre-choppers for phaco, that is before using the power. For this we have two pre-choppers which are designed both by Indians. The one that is being commonly used is Dr. Sohail Khan's pre-chopper. This can be used even for the hard cataracts.
Please note its sickle-like shape,
So you can see
sharp tip and front cutting action. Slice the hard nucleus very easily. Assisting instrument is sustainer. To divide the nucleus, sustainer hook the nucleus at equator and engage the pre-chopper as possible as proximal. Then move the two instruments toward each other, that is the goal, just like your horizontal chop, checking to ensure that the nucleus.
So there are two instruments, one is a pre-chopper and the other one is a sustainer. Same thing as there with the Dr. Pradeep Mohandas pre-choppers also.
The pre-chopper and a sustainer is used. The pre-chopper and the sustainer is used in this way, and here it is. The nucleus divides into two halves.
Chopper, please note it.
Now coming to next in technique, we have the ultrasound based IOL cutters. So these cutters can be attached to our existing phaco tip itself. This was developed by Dr. Neha Dolakia. It provides a precise and stress-free cutting of the IOL. And some surgeons are trying to use this ultrasound IOL cutter for pre-chopping also. So in this, this is a video. So this gun can be used if you
with
have a
power of
specific
30,
IOL
irrigation
or also
on with flow rate of 25 and vacuum 0. I am introducing my IOL cutter and very well it is going in, holding it and cutting so smoothly through and through. The left hand instrument is something which has helped me a lot here, and I can note that because.
Now coming to a laser precision capsulorhexis technique, which is known as a capsule laser. This is a solid state laser with a wavelength of 590 plus or minus 3 nanometer. It provides 100% continuous waves that creates a capsulotomy and can be used during cataract surgery. The trypan blue dye is first applied and the focus laser selectively absorbs the dye, creating a perfect capsulotomy within 1/3 of a second. And another great advantage with this capsule laser is that this can be attached to our existing microscope itself and just needs a separate pedal for manipulation. So this is the video. Coming to new in intraocular lenses. So as we all know, there is not much in intraocular lenses for the past 5 years, but people have started increasingly using the monofocal plus lens platform, which has got two lenses, Eyehance and Clarion. These lenses additionally provide an intermediate vision and is designed with a progressive power change and a higher order aspheric surface that adds power towards the center. So this design will minimize the dysphotopsias and does not split like the previous EDOFs. Coming to the EDOF lenses, which is the proper presbyopia correcting lenses that aim to enhance intermediate as well as near vision to a small extent. EDOF lenses achieve this by creating a single elongated focus as opposed to the overlapping near and far images which is seen in multifocal lenses. We have two lenses here, Symphony and Vivity. Symphony by J&J is a diffractive EDOF, so it has still got a little bit of dysphotopsias and reduced contrast sensitivity. Whereas VVT, which is FDA approved in 2020, is based on a monofocal platform itself, but has got a center elevation on the anterior surface with a different power, so it allows EDOF property without diffractive elements. VVT is introduced in India in 2021. Coming to another new lens, it's not new, people have started increasingly using this also. It is EDOF with multifocal property, which is known as the Synergy lens by J&J. It combines the diffractive EDOF technology as well as the multifocality. So there will not be a dropout of the intermediate distance, which was seen with many other multifocals approved in 2021. Coming to multifocals, we have the same multifocals only, but Panoptics has got an upgradation in the material. Now it is the Clarion Panoptics, and there is an Invista which is produced by Bausch & Lomb, and it is available in Europe, not yet available in India. Coming to the Clarion platform, this Clarion range of lenses was introduced in India in August 10, 2023 only. This lenses has got a new glistening-free biomaterial which is designed to have an unsurpassed optical clarity, a superior haptic stability, rotational stability, better capsular adhesion. So there is reduced rate of anterior and posterior capsular opacification. Now something new is the light adjustable IOLs. These IOLs can allow you to post-operatively titrate the IOL power. So we can adjust even for spherical as well as cylindrical power. This will happen after the IOL implantation. You have to do a UV treatment to nearly 3 to 4 weeks time after the IOL implantation when the wound has healed. So this is also FDA approved in 2017 but not available in India. So this is a light adjustable IOLs.
The new photo-switchable chromophore layer protects the LAL from uncontrolled effects resulting from accidental sunlight exposure prior to the final light treatment. During light treatments, the active shield automatically opens to allow precise light delivery from the light delivery device to adjust the lens, and then automatically re-engages following the treatments to continue to provide.
So this is something new and it's really fascinating. The results are good. Everybody in the Western country has started using this, and I think it will be soon available in India also. Now coming to new in IOL formula, this is the last slide. So there are a lot of latest IOL formulas and upgradation. Most of them are AA integrated formulas. So out of this, the most commonly used nowadays are Kane formula and Ladas formula. The Hill formula has become completely AI. Now it is the Hill RBF. Then we have our Hofer Q has got a change which is known as a Hofer Q ST, which is again a hybrid formula. Hybrid means there is an AI platform to it and also the alt one based on the previous data sets. And then another one by an Indian is also there, which is the Nalaswamy formula, which is a completely AI formula. And most of them has got very good biometric, like very less biometric errors. Thank you.
Thank you, Raki. That was an excellent presentation. If I could ask you one question. The pre-choppers that you showed, they are extremely fascinating. But I just had a doubt, it might be silly, but the end of it seems a little more sharp, right? Like, is there any, threat to injuring the capsule? That was my thought process when I first saw the video on YouTube as well. What are your thoughts on this?
So actually it has got a sustainer. With the sustainer, we sort of hook it up a little bit up in the AC. It's not like we are completely going deep into the PC level. And that sickle cell shape is there, but I think it's not that sharp. I have not used it. Maybe Manashri madam will be having some.
And this pre-chopper need not be attached to the phaco tip, correct? It
No,
can be
no.
Only
It's
the
manual.
other IOL, the other one that you showed has to be attached to a phaco tip.
Yeah.
Yeah. Okay. Excellent presentation. Thank you so much. Next, I call upon Dr. Dilip Kumar. He's a senior retina consultant and medical director of Shantiram Eye Hospital, Kurnool. He is trained in vitro-retina under Dr. Mahesh Shanmugam Shankara Eye Hospital. Over to you, Dr. Dilip.
Good afternoon, one and all. I will be talking to you about the recent updates in retina. So, ultra-wide field imaging. Any image beyond 50 degrees is termed as wide field. and in ultra wide field it captures up to 200 degree. So Octa can capture up to 55 degree. This is a slide which depicts an ultra wide field OCT and an OCT angiography in a case of ITBRVO, where you can see a non-perfusion area in the inferotemporal quadrant, which is similar what you can see with the fundus fluorescent angiography. And this is a comparison between an OCT angiography and an FFA, wherein you can see that because of the dye leakage, the abnormal vasculature is not very clearly seen in a traditional fluorescent angiography. How do we put this into clinical practice? So ultra-wide field fluorescent angiography has a promising role, and it picks up more non-perfusion area and peripheral neovascularization and helps in grading of DR even more compared to a traditional FFA. OCT helps us to assess the PVD status and helps us the dissection in plane of dissection in the VR surgery. Octa still ultra-wide field has not matched up to the role because of its acquisition time and the artifacts associated with it. And in other retinal disorders, ultra-wide field, especially in pediatric retina like Coats disease, the peripheral telangiectatic vessels can be easily seen. And in FEVR, the peripheral non-perfusion area and where we can do a targeted laser is seen. Uveitis, vasculitis can be picked up, and more cases are diagnosed because of this ultra-wide field imaging. One other use of fluorescent angiography is intraoperatively. We just attach an exciter filter to the microscope and it tells us microvascular leakage, non-perfusion and vascular filling. Based on this, we can reduce the post-operative vitreous hemorrhage incidence reduction because we can target the areas during surgery wherein when it shows non-perfusion area and we have skipped anything, so immediately we can do laser. And also better delamination of the membranes is possible because of the contrast it induces. So this is a photograph showing where a surgeon easily delaminates the membrane nasal to the disc with the help of dye. Geographic atrophy, this is the most talked about everywhere now. So until now we were not having any treatment for this, but now recently FDA has approved 2 drugs, anti-complement drugs, that is pegcetacoplan and avastin captod pegol, which can be injected monthly or alternate month, but one has to remember that it doesn't delay doesn't halt the disease, it just delays the progression. So the most important side effect to be noted during this is the ischemic optic neuropathy and its conversion into wet AMD. This is a photograph where the upper photo right eye shows the patient treated with a pegcetacoplan over a period of 2 years, wherein you can see there is a minimal increase in the size of geographic atrophy, whereas the left eye, which is untreated, you can see considerable increase in the geographic atrophy area. Mactal, another disease which doesn't have treatment until now, has a promising treatment in pipeline which specifically targets ciliary neurotrophic factor. It's again a gene therapy which is injected into the vitreous cavity. It is told that it prevents the loss of ellipsoid zone by 36% and also reduces the loss of reading pass speed by 68%. It's pending for approval. The most widely used aflibercept injection now has come up with an high dose with an objective of prolonging ocular VEGF inhibition so that the number of injections comes down. The safety profile is comparable with the normal 2 milligram dosing. So this recent studies have shown that the patient can be with injection-free interval up to 24 weeks. Optogenetics, there's nothing, it's a type of gene therapy. As we all are aware, in advanced retinal degeneration, there is complete loss of photoreceptors. So this photoreceptor has some sensitive protein called as an opsin. So in cases where there is complete loss of photoreceptor, we inject a drug which sensitizes the bipolar cells to induce this opsin protein so that it can transduce the visual pathway again. So one important thing is it is not specific to any genetic mutation and a routine 3-week steroid prophylaxis has to be given. No adverse events have been noted. Over a period of 76 weeks, we can notice 56% of improvement is noticed. AI, as in every other field, even in retina, it is possible because of the imaging nature of the retina. Deep learning module is most commonly used. These are the various applications and the devices which are used. In most commonly AI is used in diabetic retinopathy for grading, predicting and prognosticating as well. ROP and automation is possible now. It can easily predict into whether this eye or the baby would develop into stage 2 or stage 3 and guides us in the treatment, and also classifying the diseases in AMD. The only disadvantage is with the black box phenomenon, that is we are left out with inputs and outputs, but we do not know the reasoning why, how did the machine gives us this data apart from we giving us input. This is the only thing we are kept hidden about that. One interesting thing is in surgical retina is about using AI in retinal detachment. The most common question is in an RD surgery, the patient would ask us, will I get my vision back? So using this AI, apart from macula on and off status, we can incorporate macular OCT and ultra wide field imaging using a fusion model. It takes into consideration height of the foveal detachment, the ellipsoids on breaks, outer retinal corrugation, and tells whether the patient would will develop vision beyond 618 or less than 680. So this is the same thing which is the model. And the last is robotics in retinal surgery. So with the advent of subretinal injection and gene therapy, precision and elimination of hand tremors has been imperative. So robotics is used very commonly in these procedures like macular surgery, subretinal injection and retinal vein cannulation. In the surgical state, two systems are available now, that is precise surgical system and KU Leuven manipulator system. A robotic device would consist of a motion controller with an instrument manipulator, wherein you can load the forceps or a needle or any other desirable instruments where you need to work on, and it is integrated with OCT so that you know the positioning of the tool and its precision. The resolution of the precision is up to 10 microns. This is a photograph where a surgeon is sitting and doing a subretinal injection. You can see the right hand is handling the motion controller, and you can see this is the instrument manipulator, wherein the instrument injection needle forceps can be loaded onto it. It has a conical tip which is docked into this adapter, and the procedure is carried out. So this has a precision and more thing. It's very importantly used in subretinal injection and gene therapy. Thank you.
That was an excellent talk. Thank you very much. Do any of the audience have a question?
So that was about the optogenetics, was very fascinating. So is it, is it being...
no, ma'am, it is still in phase 3.
It's phase 3, it's
yeah,
not come out,
They
right?
are
Because
doing it for Stargardt's and retinitis
yeah,
pigmentosa.
that's what, it's showed very promising results.
Yes, ma'am. Thank you.
Doctor, next we have our oculoplasty and orbit update. It will be delivered by Dr. V. Anu Chandran. Over to you, Dr. Anju.
Thank you, Dr. Sugaranjani, for giving me this not so sweet task of compiling so many articles together. But in the process, I learnt a lot too. So it's about orbit, or I've tried to summarize or pack in as many articles as possible. So my only disclosures are, we believe that we are the protectors of the eye, the head, neck, and so on. So beware of any foray into the other territories. Thyroid eye disease forms a major chunk of our OPD, and the advances have been revolutionary over a period of time. In that, this particular article, what they studied was the use of 5-fluorouracil in the treatment of myopathy. So generally patients, even if they cross the active disease state, they still complain of diplopia and they have squint issues. So they have used the property where metabolically active cells such as fibroblasts are being arrested. And here they've used an needle to inject it into the orbit adjacent to the affected extraocular muscle to deliver the drug. According to their study, they claimed that the esotropia improved and the patient complained of lesser diplopia in the postoperative period. The second thing was a review article about the use of triamcinolone injection in treatment of lid retraction. So triamcinolone works by suppressing the immune response over a period of time. Being a review article, what they noted was the use of triamcinolone as subconjunctival or periocular was more efficacious in patients who had an active thyroid eye disease compared to inactive. And the effect lasts for nearly 24 weeks, which is good enough for the patients. And sooner the treatment, the better the outcome. When they compared it with injection botulinum toxin, they found it to be more efficacious because there was local perfusion into the soft tissues. So amniotic membrane transplantation has been described widely in cornea and ocular surface diseases. So how is it relevant in oculoplasty? So its nature as a transparent material with good color match and texture, and obviously a plus for us is sparing the donor site, and also its anti-adhesive properties served as a substrate graft and scaffold and reduced healing time in many procedures in orbit, eyelid and lacrimal surgeries. One interesting use that I felt was it was used to wrap muscles in an orbital fracture repair where there was adherence syndrome. The other would be in socket reconstruction and cicatricial entropion, and as well as adjuvants for flap and reconstructive surgeries. So this probably would be a game changer. I'm yet to use it in my practice. That is the use of tranexamic acid in eyelid procedures such as ptosis and blepharoplasty. So according to this randomized control study, they used the properties of tranexamic acid as an antifibrinolytic, and they mixed it with their routine lignocaine composition. And what they studied was that it reduced the ecchymosis and lid edema in the post-operative period. So this is probably a game changer. I believe most of the dermatologists are already using it in their practice. So this is called plasma exeresis, where the property plasma ablation, that is the solid state of tissues are converted into gaseous state directly with the help of ionized energy. And this is without direct contact with tissues. And it ensures accurate and precise ablation of the skin layers and avoids damage to the underlying structures. So where this has been very useful is in peripunctal lesions, because you want the puncta to be intact, and if there is excess heat delivered, it can result in a punctal stenosis. The only disclaimer would be to exclude lesions with a suspicion of malignancy. This was an interesting image that I came across where we all know that vitiligo is an autoimmune disease. So when you have segmental disease confined to the eyelid, this was a drug that was found to be useful. It is ruxolitinib, which is a selective inhibitor of Janus kinase. It is a topical, it comes in a topical formulation of 1.5%. The only drawback of this is a tube costs about 10,000 rupees. So no talk would be complete without mentioning recent advances in retinoblastoma. These are two excellent review articles, one which has come from our very own Indian subcontinent, and Dr. Advaita happened to be my co-fellow too. So I would not go into the details, but a particular thing would be the targeted therapy that has come of late, where they have started to use immunotherapy, immune checkpoint inhibitors, and matrix metalloproteinases in treatment of retinoblastoma. Also, chemoplaque using topotecan, which is used as an episcleral plaque, that is also said to slowly release the drug into the vitreous tissues. IgG4, this is an entity that as ophthalmologists we all should be aware, and the very reason that you would see a hike in articles on the same. So this was a beautiful article which mentioned this topic under all the subtopics. So one, you can have periocular painless swelling. It can affect virtually all structures. Orbital imaging is key, and also incisional biopsy with a histopathological examination will clinch the diagnosis. You need to refer such cases to a rheumatologist to rule out any systemic involvement, and obviously it's a comprehensive treatment. So not just looking at ophthalmological articles, you need to look a little away from it too, often to improve your treatment, such as in cases of myasthenia gravis. So we are all aware of how pyridostigmine is being used, as well as plasma exchange is being used. So it was interesting to note that these are obviously in trial stage. So they have used complement inhibitors such as eculizumab, ravulizumab, and also neonatal FC receptors, which actually help in the recycling of antibodies. Those are the AChR antibodies that are there in myasthenia gravis. So I leave you to read the name of the drug yourself because it's quite tongue twisting. So I end on a very light note. This was by one of my teachers, Dr. Shahid Alam. So he came across a very interesting phenomenon called lacrimal flatus, which was observed in patients who had undergone probing. And he noted that on pressing around the region of the lacrimal sac, you would see bubbles or you would hear a sound. So the explanation for this was probably due to probing. The valve of Hasner resulted in reflux of air that was trapped within. So if you have patients coming to you saying that, yes, I hear a weird noise, then you can reassure them saying the same. So these were the journals that helped me sum up most of my articles here. And I'm also happy to inform that in 2026, we will be hosting the annual conference of Oculoplastic Associations of India. Thank you.
Brilliant talk, I must say. If I could ask you one
Yeah.
question. The tranexamic acid, the injection, I think it would be a game changer because
True.
post your lid surgeries, the main thing that is disappointing for the patient when they see the next day is the, the
Edema and
hematoma.
echinosis, yes.
So is it available? You said you haven't yet had the experience to use it.
Yeah, I'm currently studying to see if it is actually safe in practice, but yes, it is available. It is freely available. It is in fact being used by anesthetists. They give it in the perioperative period.
Any other question?
So very interesting to note about the 5-flow uracil injection. So it's not into the muscle; it's into the orbit.
Adjacent, yes, orbit. So according to this article, in one particular patient, because the patient hid the history of anticoagulants, they did have retrobulbar hemorrhage. But they are not exactly clear as to what period they gave these injections and how many injections it took for them to come to this outcome.
When active or in the fibrotic stage.
So what they mentioned was the active disease, where initially they had given steroids, but then the restrictive component had already set in.
So a bit of fibrosis is already
Yes, set in. Yeah.
Any other questions?
Yeah.
Thank you, Dr. Anjan.
Ginny will speak on
Corneal
exploring the corneal chronicles. Over to you.
Dr. John is caught up in another session, so I'll be presenting my presentation, Exploring the Cornea Chronicles. If anything that COVID has taught us, it is to move away from the human cornea because the availability can go down at any point. So this is a new artificial cornea that has come into being, EndoArt, and this is not a far-fetched dream, I must say, because it is already being used in LV Prasad Eye Institute. So this is an artificial cornea. The main purpose of this is to prevent the imbibition of the fluid in a Fuchs dystrophy or a failed graft. So the surgical process is fairly simple. But unlike a human cornea, you can actually touch this artificial cornea because you're not destroying any endothelial cells. And the only surgical step which is different from a desec that we do is a single suture that is put at the 12 o'clock. And long-term studies have shown that this is quite reliable, and the studies have already started in India as well. The second artificial cornea that is available is Xenia. This is used in keratoconus. This can be implanted in the intrastromal layer of the cornea. Femtosecond laser is used to create the stromal pocket, just like in a smile surgery, and this particular lenticule, Xenia, can be inserted in this intrastromal pocket that is created, and this brings about corneal stabilization and visual improvement. And it is also already being used in India as well in the study stage. So to get rid of both the corneal implants altogether, we now have the injection of cultured corneal endothelial cells. This is being exclusively propagated by the Kyoto group by Kinoshita et al. So this is a small surgery where the cells, the endothelial cells can be taken from a normal individual, cultured, and according to the reports, it can be used can be injected in up to 300 individuals with endothelial dysfunction. And the requirement after the injection is that the patient needs to maintain a head down position, so these endothelial cells actually stick to the endothelium, cultured endothelial cells. And long-term reports, they have been publishing their 5-year follow-up reports as well. And what is interesting is that the endothelial cell density, which tends to fall after a DMEC or a DSEC surgery, they compared the outcomes of just an injection with the the fall in endothelial cell density over a period of time, and they have reported that it is comparable. So the 5-year follow-up of endothelial cell density is much similar to a surgery, so this could be a game changer. The other new advent, and we need to be proud that this is by an Indian ophthalmologist, by Dr. Susan Jacob, is the customized CARES. So this is a keratoconus topography with storing an inferior steepening. We have already know what does CARES do. So it just flattens the area of steepening. So now Dr. Susan Jacob has come up with a way to customize this by making segments such that in the area of maximum steepening, the segment is thicker, and where there is lesser steepening, the segment is thinner. This is a small video showing that. This is how it's prepared from a normal corneal structure. Then this is the normogram that they use to customize it. I mean, this is the diagram that they use. A normogram has not yet been released by the CARES group. And then they customize it, and then they make a thinner segment for the lesser steepening area, and the insertion is fairly similar to the intacts that we use. And they have published that they do have good results coming out with it. So topical losartan eye drops is available in the Western countries now. So this inhibits the tumor growth factor beta, which is involved in the myofibroblast formation. So this is not commercially available. So pure losartan powdered is actually compounded with a balanced salt solution, and the recommended dose is 0.8 milligram. And this is used 6 times a day for 4 to 6 months. There is no reported toxicity, but it is quite expensive. It's available in the Western countries, and they have reported a good decrease in the corneal fibrosis haze in many conditions, including post-PRK. So insulin has played a vital role, and now there is topical insulin eye drops that can be prepared. Dr. Saji Hussain does have a video on YouTube. You can go check it out on how to prepare an insulin eye drop. So it acts as an insulin growth factor, and it plays a vital role in wound healing and regulating the cell growth and proliferation. And it also is known to make the corneal sensitivity recover. So it is a great adjuvant that you can give along with your lubricants for a neurotrophic ulcer. So the recent entry into the market is definitely the Seca drops. I'm sure all of you have heard about it. And the Opus 1, 2, 3 trials have established the safety of these drops. So these can be, these are act in controlling the ocular surface inflammation in dry eye mainly, and they can be given, they are prescribed 2 times a day. The advantage over cyclosporin is that they do not need any refrigeration. The only limiting factor probably is the cost. It is slightly more expensive. It started off in around 13,000 to 15,000 for the drops, but now the company has actually reduced it to around 2,500 is what I've heard. And this is a study published in the Indian Journal of Ophthalmology, which has shown beneficial for dry eye patients. This is my favorite update, I could say. So this is a rose Bengal mediated photodynamic, like a cross-linking therapy for corneal ulcers, which has been already propagated. So in the cross-linking that we use the riboflavin, but this is a rose Bengal mediated, and the light source that is used is slightly different, and it is propagated for mainly corneal ulcers of 300 micron thickness, and the reactive oxygen species generated is known to kill these organisms. It has been reported to be more favorable in Fusarium species than the Aspergillus species, but this is an interesting update to watch out for in the future. And also the corneal dystrophy classification has been released this year. There are minor changes. I would say I have read it a couple of times, but still it takes multiple readings to actually register everything. But do have a look at it. There are slight changes in the ICD classification, and Pentacam in this year ESCRS released their anti-segment OCT. So we all know that Pentacam has the corneal topographer, but they also released their anti-segment OCT this year, and look at the magnificent images that it gives. It has a fantastic resolution, 1.9 microns, so you can actually see the Bowman's membrane and the scar, and these are the beautiful pictures that they released. It is, I'm not sure if anybody has it in India yet. I think the NN group has it, but it's a fantastic machine. Yeah. Thank you very much for your patient listening. If there are no questions, can we move on to the next presentation? Calling upon Dr. John Davis Sakara. He needs no introduction. He will be giving us the glaucoma update for the year.
Thank you, Dr. Sugaranjini, for organizing this. So this is a very, very useful talk. I think this is going to be the one which is going to be updated every year, because there is no other thing. That is how it is supposed to be. So glaucoma, there are lots of things in glaucoma. Unfortunately, I could cover only a little bit, and I will keep updating more soon. So if you look at it, I am just looking at it at the various parts of the glaucoma evaluation, treatment and all that. So in diagnostic techniques, so first glaucoma, we look at the IOP. So IOP, we know we have all the other devices. We have the non-contact tonometer, the tonopen, the rebound tonometer, on all that. Then this IOP by contact lens is the Sensimed triggerfish. So it's the contact lens which has a IOP measurement option. So this is using the stretching of the contact lens. It is converted into the IOP measurements by using artificial intelligence. So that was one thing. But there is another thing also. There's an intraocular implant to measure the IOP. So that was the iMate IO. So that came out first, and that was supposed to be done during cataract surgery. You put in a CTR-like device with the sensor on it, along with the IOL, that stays inside the capsular bag and keeps monitoring the IOP, and it can be monitored by using a sensor which basically sends in radio signals to elicit a response, and that sends the values back. So that was one thing, and this can give an actual continuous true measurement of the intraocular pressure. And they recently came out with iMate SC, which is a suprachoroidal device. So this is implanted here and keeps continuously measuring the IOP. So these are some of the things in IOP, but for regular usage, we have so many advancements in the rebound tonometer and all that, which can be used in different positions. Diagnostic modalities, there are lots of updates. So I'm just picking out only a few. So one is the detection of apoptosing retinal cells. So this allows you to look at apoptosis on the retina and allows you to see if there is any progression of the glaucoma changes. So that is RGC death can be looked at. And in anterior segment imaging, we can also look at things in 3D. So 3D anterior segment OCT is being available, and you can look at it in more detail. And as always, the resolution of all these things keeps getting better and better. And you just saw the anterior segment OCT has become so sharp now. And along with that, you can even look at the something you call 4D is basically 3D with movement. So you can look at ultrasound in 3D and 4D. So that is the UBM and regular ultrasound has gotten better at giving you the position also. Then for looking at the angle, you have the portable angle imaging devices. So you can use this gonio pen to directly take an image of the angle. It's a contact procedure. You just place it on the angle and you get a direct gonio image. And then there is the GS1, which is a desktop device which takes a complete 360-degree angle view. So it is a contact device. It is a 16 mirror gonioprism which touches on the eye, and the device takes multiple images, stitches them together to get you a complete image of the angle. So that is what is important. Gonioscopy, actual visualization, is what is important rather than the anterior segment OCT. So functional testing, if you see, we have seen the last few years has been the era of virtual reality perimetry. Lots of virtual reality headsets, starting from the very low cost one, that is a periscreener. Now a lot of virtual reality headsets have not only perimetry, they also have visual acuity, contrast sensitivity, stereopsis testing, so many things built in now. Even pupillometry has been incorporated in some of the newer ones. So, and then the next level of the virtual reality perimetry will be avoiding the patient problem. So this is a subjective test because the patient has to subjectively press a button to let us know. So by using this EEG electrodes on the device, N-goggle tries to remove the subjectivity of perimetry and try to get accurate measurements of perimetry by getting the EEG readings. As soon as the patient sees a spot, the EEG knows that the patient has seen a spot. So that is the advance in that. So there's a lot of advances in AI, artificial intelligence in glaucoma, starting from OCT segmentation to fundus, detecting early glaucoma by from smartphone fundus images and so on. But there's also a lot in perimetry. So pre-perimetric glaucoma is now possible to detect pre-perimetric glaucoma from perimetry, and you can differentiate various types of visual fields defects by using AI. And there is a group which was able to predict the future 5.5 years of visual fields of a patient by training their AI with 32,000 visual fields. So you can tell a patient that if your eye pressure is maintained within this range of IOP, this will be your visual field in the next 5 years. So that is also possible with AI. Medications, so there's been a lot of medications which have come. So I have not gone into the research medication, but latanoprostine, netasudil, ripasudil all has come, and there is a triple drug combination also now. But more importantly, the medication delivery systems have also changed. So there is now an implant which keeps releasing travoprost. So iDose is an implant which is implanted and gives you a slow release of travoprost. It's a 75 microgram implant which keeps releasing slowly. And also there are devices which helps to improve the medication adherence, starting from the eye drop guides to the guides with sensors to let you know how many times a day it has been, whether it has been used every day, and it keeps a documentation of the medication use. Another thing is the iNovia Optojet and the ECM devices, which tries to spray the medication into the eye. So how it works is the medication is kept in front of the eye, and this device sprays the medication onto the surface of the eye, and that allows you to use very minimal amounts of medication, because that is all that is needed. And because the sensor looks at the eye properly and sends the medication in, it is always accurately given, and it is monitored also. So this is probably the future of eye drops. No longer eye drops, it's going to be a jet of medication sprayed into the eye. So many things about lasers. There is now direct SLT which uses lasers which allows you to do the SLT from outside. So ab externo through the sclera, it allows you to do the SLT laser on a machine like this. This is the Eagle machine. This is regular SLT with a gonioscope, and internally this is from external. And there is the excimer laser trabeculostomy. There is the laser mix. There is this one. You go in with the laser probe and make a hole using that. And micropulse transscleral laser is also there. That's been a few years. So that is another method of treating glaucoma, and this can be used even in eyes with good vision. Pattern scanning SLT is there. So that allows you to put all the spots very quickly. It's just similar as the Pascal. And surgical advances in implants, there is the glaucoma drainage device, the iWatch, which has a variable IOP control. So you can see what is the eye pressure control and then use this device which is called an eye watch, and this has magnets here which allows you to adjust the resistance to flow of the tube. So that allows you to control the IOP after the surgery. You can titrate the IOP after surgery. Due to lack of time, I'm not going into the other surgical advances and genetics and all that. Thank you. I'll give you more updates on glaucoma. Unfortunately, I could cover only a little bit of it. Thank you.
I think you've done a great job. If I could ask you one question, Dr. John. The 3D OCT that you showed was really interesting. I mean, as a postgraduate, I used to wonder, gonioscopy, you have to touch the eye of the patient. Why can't we just image the entire angle? Like, do you feel this is going to, overthrow the gonioscopy? Like, do you feel it can replace it?
So this imaging of the angle, it is still a contact procedure, unfortunately, because of the laws of physics. It does not allow you to visualize the angle without crossing the critical angle. So it is still a contact procedure, but the advantage is it allows you to take the entire picture and then you can look at it at leisure, because directly looking at the gonioscopy several times is a very difficult procedure for a patient. But and asking about whether it can be done non-contact, maybe we can improve I don't know, ASOCT to such an extent that it is possible in the future, but not crossing the critical angle with visible light.
And what you showed about the eye drops that can be monitored, the monitor which can be fixed to the eye drop, I think that would help in analyzing whether your patient is compliant to the medication also, I guess.
Exactly. So that is one thing which we all forget. We diagnose the disease and we prescribe the treatment, but the patient does not often even understand what we have told. So this sort of thing will allow you to monitor the patient's treatment, which is actually the most important part. So that is what we have to be always aware of.
Thank you. That brings us